play. Well, hi, and welcome back. It's October 21st for another Lunch and Learn. I'm here with a dear friend and colleague, Mandy Blackmon, who is an absolutely outstanding physical therapist. I say that as a patient. She has fixed my headaches and fixed my husband more times than we can count. But anyway, she and I I think we first met through Atlanta Ballet, our work
We
there.
did. And Eden, actually.
Eden, yeah, through the eating disorder community as well. So we've got a lot of overlaps, but what that often comes down to is this topic of hypermobility. So I wanted her to come and help us understand the role of the physical therapist in the hypermobile patient. So thanks for being here.
Yeah, I'm excited to be here. Thanks for having me. So I'm a
Awesome.
PT practicing here in the Atlanta area for over 20 years now. My special interest is really dance medicine and performing arts medicine, which led me into the world of dealing with a lot of patients with hypermobility spectrum disorder and even Ehlers-Danlos disorder. So now a huge majority of my practice is actually patients who are maybe former dancers or not dancers, but are dealing with that hypermobility and a lot of chronic pain.
Yes.
So I've
Yes.
owned my own practice, and then I co-own Atlanta Dance Medicine that has 4 locations here in the Atlanta area. And yeah, we just serve all the people.
Yeah, and importantly, not just dancers, right? Like there's a whole bunch of hypermobile folks who are not dancers and are walking around either not knowing they're hypermobile or knowing, but not knowing where to get care. So let's just start with like the basic team approach for folks with hypermobility. Like how would one know if they are hypermobile outside of party tricks, and why would they want to call a physical therapist?
Yeah, I actually think that's one of my main roles is I'm often the first healthcare practitioner to tell a patient that I suspect they are on that hypermobility spectrum. I try not to give too many labels, and I actually don't love for many of my patients to have a formal diagnosis in their medical chart. But I like to say things like signs and symptoms consistent with being on a spectrum of some connective tissue hypermobility, because it truly is a spectrum, and patients can present everywhere from having one joint that is hypermobile all the way up to a fully symptomatic multi-system issue that we might consider full-on Ehlers-Danlos syndrome. So I think part of the issue is that many healthcare practitioners, physicians, physical therapists, um, mental health providers very much practice in a silo.
Yeah.
And it seems like a lot of, especially specialists, aren't really willing to look outside of whatever they specialize in and start putting the whole picture together. So I find that occasionally I am the quarterback that starts connecting the dots, because if you are a hypermobile patient, what patients don't realize, it's not just about having bendy joints. It really can affect every single system in the body, because the system is made up of connective tissue. So it might be me saying, oh, your GI stuff is related to your bladder issues, is related to your gynecological complaints, is related to your migraine headaches, is related to your rashes, is related to your poor eyesight, is related to your food allergies, and on and on and on. And so a lot of times I'm the first person to connect those dots, which can be validating, but also very overwhelming for a patient, which is when I like to have my team to then refer to, because obviously I cannot manage these patients all by myself.
Yeah, nor should you. Medicine's a team sport, right? And I think that's really my message often to dietitians and therapists and manual therapy people like you, which is like, you guys are the ones spending an hour with these patients. You're doing
Mhm.
manipulations while, the patient's talking about all kinds of things. And so it's really, unfortunately, because of the nature of commercial medicine, if you've got 10 minutes with a physician who's only looking at like your hand, not even all of your skeleton, you're hearing,
Mhm.
oh yeah, my week was really busy. I saw 4 different medical specialists this week. And so that's for me also a clue, like there's probably something going on if you've got 5 different specialists who are seeing you. So you mentioned maybe not wanting to get a diagnosis in the chart. Do you want to say more about
Mhm.
that?
Yeah, I think we just never know what's going to happen with healthcare. And a lot of these patients are getting diagnosed or, suspicion earlier and earlier. And maybe they don't have life insurance. Maybe they don't have long-term disability insurance. Maybe they are in a place where their health insurance is not tied to their employment,
Yep.
and they may have to go through underwriting. So I try, we never know what's going to happen in the healthcare system either with just pre-existing conditions. So I tend to counsel patients against getting that full diagnosis in the chart if they can help it. And I usually do the same with genetic testing because, as you and I know, there is no genetic test for the hypermobile type of EDS. However, you and I share a patient that we were surprised about recently that did have a positive genetic test, which was validating for her, but it's not as much of an issue in that case as far as having a pre-existing condition in the chart.
Yes, absolutely. I mean, we don't know, but part of any testing, whether it's ordering a CT scan or a blood test, I should be able to tell you the risks and benefits of that and understanding the context in which our healthcare system is working right now to have any kind of genetic label. For some people, is super validating. It opens doors, it gets them the
Mhm.
care that they need. And for other folks, I think particularly with this hypermobility spectrum, assuming that I don't think that you've got like vascular EDS that needs to get managed in a very different way. For hypermobile
Absolutely.
EDS, most common type, I'm going to do the same thing for you, whether I think you're just benign hypermobility versus like true hypermobile EDS. So we can wink wink like think, yep, it's probably hypermobile EDS, but we'll just call it hypermobility spectrum disorder. So anyway,
Yeah,
so like what does that look
we
like?
are on the same page.
Yes, exactly. What does that look like when someone comes to you? They may have chronic pain. Like, tell us what this typical patient is like and
Yeah,
we can help
a
them.
lot of times when they come to me, it can be a couple different scenarios. Often they have been an athlete or a dancer and have functioned at a very, very high level for a very long time. And they've had some incident that has sort of been the tipping point for them that has sent them over into a chronic pain state or a persistent pain state. It can be a very low speed car accident, it could be the loss of a parent, it could be even a grade one ankle sprain. It can be something very, very small or something very, very big, mental health or physical, that can just sort of tip them over. So that's one thing I often see. The other is um, if that person was a high level athlete or even a recreational athlete and or a dancer, and then they stopped moving.
Mhm.
Say it's that dancer who all the way through high school was dancing 15 hours a week and then they go to college. The stop moving can set them off into that chronic and persistent pain as well. And then other times it's patients who really have been in chronic pain most of their life and maybe have failed PT in other places because they went for their knee for 4 weeks and got discharged, and they went for their shoulder for 4 weeks and got discharged, or they went for their headaches for 4 weeks and got discharged. So it's those patients that I tend to have forever and ever. Once
Mhm.
they end up in my office, I try to get them to a point where it's more of a maintenance thing, right? Like, I don't want to see you every week. I don't
Mhm.
have time, and you probably can't afford to see me every week. So a lot of times it's those types of patients that I'll see once a week for a couple weeks and then get to every other week and then get to every 3 weeks. And I love to get those patients to the point where I see them every 6, 8 weeks just for some maintenance, like put out the fires, check in on their home exercise program, just see
Yeah.
how they're doing overall.
Yeah, and I think this is the take home message for folks who are whether you're just a quote normal weekend warrior or you're someone with hypermobility who has like recurrent various injuries. Prevention is such a huge part of that, and often our medical system is reactive. Like, honestly, like, it's hard to get insurance to pay for a physical therapist for maintenance, right? There has to be a
Hmm.
diagnosis and a problem that you're trying to solve. And so sometimes there's ways to kind of fudge that a little bit, but I think
Hmm.
particularly for folks outside the insurance network, like you can just go see a physical therapist and be like, help me with some home exercises, help me know how to like see you less. I would like to, just like a car, you got to like tune it up and put gas in it. Our bodies are the
Hmm.
same, and we need to be able to kind of maintain things before you end up with a big diagnosis. So part of the team, when people come to me for EDS diagnoses or how to medically manage it, I'm looking just like you are, like who is the team who's supporting you so that we can keep you out of the hospital or out of, major surgery.
Yes. And the surgery is a big one because so many of these patients do have things that might be surgical, but many of them do not do well with surgery.
Mhm. That's
So
right.
if I can get them stabilized, get them stronger, get them managed with manual therapy, dry needling, whatever else, and avoid surgery, a lot of times that can be very helpful in the long run.
Historically,
Surgeries become a domino effect.
yes, correct. It's like one after another. It's
Hmm.
often like how we say like hip fractures or life-ending illnesses. It's not the fracture,
Hmm.
it's the fact that you become deconditioned and then you're higher risk for pneumonia, and then you get pneumonia and you're in the hospital. It's like on and on. Uh,
Hmm.
so big picture. So um, historically, folks were told, and certainly what I was taught in my very minimal education on these topics, which is hypermobile people should not be lifting weights. They're too loosey-goosey, and so weightlifting is not part of that. What are your thoughts about kind of modern mentality around strength building for these folks?
Exactly the opposite. These patients need to be moving and they need to be building and then maintaining muscle mass to stabilize their joints.
Mhm.
I think a lot of times these patients, their muscles are sort of holding onto their joints for dear life anyway. So they can develop a lot more trigger points and tension than some of their counterparts, which is why they feel tight when we know they're not tight, right? So a lot of times if we can calm those trigger points down, but then strengthen those muscles so that they're working in a better way to co-contract around the joints and stabilize, it's going to be much more healthy in the long run for every joint in the body.
Do you have any words of wisdom for someone, like, especially if they're in a community where there may not be a hypermobile specialist in the physical therapy world, how to like self-advocate in the general world of physical therapy, or how to pace out those? I often hear from patients, oh, I went to, the big box, physical therapy
XYZ
practices.
PT.
Yeah, yeah, the ones, big ones. And then, they did all these things and I felt so much worse after my physical therapy experience. I don't want to ever go back. Like, are there ways that people can advocate eh, in those?
I think it's really looking for a PT that has the time to sit and listen.
Yeah.
Many PTs in those big box places are actually excellent clinicians and they are functioning within the environment in which they work, which is not very great. So finding, especially if the patient does have the financial resources, finding a PT who at least is one-on-one for at least 30 to 40 minutes that has the time and bandwidth to listen. And often it ends up being the patient educating the PT, but then many PTs will go and deep dive and get themselves more information. So, one of my favorite resources is the book Disjointed. I think I shared it with you a bit ago.
Yes, it's great.
I get all my patients to buy that book because it is so validating and there's information in there that they can share with other healthcare practitioners who aren't aware of hypermobility spectrum disorder.
Yeah, absolutely. And I like that book too. I will say, I think I sat down
It's
and
dense.
it's dense and it's like $50. And I was like, are you kidding me? And you're like, just buy it, because it's not just here is physical therapy for a hypermobile person. It talks about all the connective tissue, how all the stuff is connected, and then goes into other topics like MCAS and POTS and other
Mhm.
kind of co-occurring illnesses, which is what lands in my practice.
Yeah,
Um,
and many people just don't realize that those things are connected to their bendy bodies. They don't see it. I didn't know about MCAS until that book came out in 2020.
mhm. Yeah, awesome. Are there any resources? I have kind of an auto text replace that I give to every patient who walks in the door with like people on social media that they should follow. This book, Disjointed, certain podcasts like Linda Bluestein's Bendy Bodies podcast. Are there things you
Yeah,
point your people to all the time?
that's one of my favorites is Linda Bluestein's Bendy Bodies. She's so great and doing such a good job at covering all these topics holistically. Those are my big ones. There's a guy I recently just started following on Instagram who's doing a lot of exercise and strength training for hypermobility.
Okay.
I'm going to have to look him up and I will get back to you. But I actually learned about him from some of my hypermobile patients, and he's putting out some pretty quality information.
Okay.
And then obviously Atlanta Dance Medicine is a resource. Any of the dance medicine world, I do encourage these patients to stay off the Facebook support groups.
Why is
I
that?
think that can be a deep, dark hole where patients are really, there's a lot of misinformation and there's a lot of negativity. And I think we have a lot of tools to offer these patients, and
Mhm.
every single patient with this diagnosis or suspected diagnosis is going to present differently. And I think getting into some of those support groups can be much more of a hindrance than it is a positive thing.
Yeah, as I tell every patient that walks in the door, like, by the time you see me, I know you're frustrated with our healthcare system and really trying to find a place. And I think like breeds like clearly our healthcare system has a lot of challenges. I say that as a consumer of healthcare, as a patient myself. But I do find when you're in environments like that, it just becomes like everyone's against me. And
Mhm.
obviously you and I are advocates for these folks, but I do think that any clinician who is still working in healthcare is still trying to fight the fight to give patients the care that they need. And so really allowing us to partner with our patients is really the modality. So there's some benefit in that, like, hey, who'd you see for this issue? Oh, this person's good. Great. It's a great resource, but don't get down the rabbit hole, I think is
Yes.
the message with
The,
that.
the deep, dark well.
Yes. Yep. We have a patient question. How can physical
Mhm.
therapy help degenerative disc disease and obliteration of the intervertebral disc space in a lower back? So less about, hypermobility, but just generally about what a lot of us are facing about lower back pain and disc disease. Do you have any thoughts about that?
Absolutely. I think one of the important things to note is that degenerative disc disease is actually just normal aging.
Mhm.
And if
Especially.
I if I took an X-ray of 100 people our age, we're about the same age, most whether they had back pain or not, those images would look very similar. And same thing if I took 100 people in their 60s, whether they had back pain or not, their images would look very similar.
Mhm.
So that natural degeneration of the spine and that narrowing of those disc spaces and the spaces between the vertebra where the nerves exit is all fairly normal. Physical therapy treats the symptoms.
Mhm.
So this person with identical x-rays or identical MRIs, one may have back pain and the other may not. So I'm there to treat the symptoms, not necessarily the pathology,
Yes, that's right. And
which
what
is, go
Sorry.
ahead.
What's so interesting, like the last study that I looked at this, and I'm certainly not a neurosurgeon, so I have no doubt that my neurosurgery colleagues have much deeper data. But basically, if you take two people with disc disease and one gets physical therapy and one has surgery immediately, at a year, their outcomes are more or less the same. And so it really is about the symptoms. Like if you're a trial attorney that's got to be standing on your feet and you've got like really horrific, nerve pain, surgery may be indicated right up front.
Mhm.
But
Absolutely.
healing the body is more than just fixing the structure, and sometimes fixing the structure doesn't fully fix the symptoms. So again,
Exactly. Because it may not be coming from that actual degeneration. It might be coming from a different source. And most surgeons, and I will say we have some fantastic surgeons here in Atlanta.
Mhm.
I know your patients are all over the place, but most surgeons are very conservative here and will refer to physical therapy to a good physical therapist before they even consider speaking with that patient about surgery, which is a really good thing.
Yeah, absolutely. Not just because insurance is trying to avoid paying for the surgery, but because it's the right thing to do.
Exactly.
Right. Not just because insurance is trying to practice medicine, whatever. Side note. Anything else that you think is important for folks who are struggling with chronic pain or feeling like they're a little lost? Any words of wisdom for them before we close out today?
I think a piece that's become very passionate for both you and I very recently is the hormonal component,
Oh yeah.
because we are sharing so many clients who are also in this perimenopause realm. And it's like, is this my hypermobility acting up? Or is this a hormonal component on top of my hypermobility? And even patients who aren't hypermobile that might have chronic pain that has nothing to do with HSD, um, you know, there might be other players involved. So I think, again, that team approach and being willing to kind of step outside your normal physicians that only do their one thing and look at it from a bigger perspective is really, really helpful.
Yeah, what Mandy's referring to for the peanut gallery is musculoskeletal syndrome of menopause is how they're referring to it now. So
Hmm.
if you're kind of a middle-aged woman, and I say that as one, which sounds old, but anyway, over the age of 40, when you start seeing people get frozen shoulder or plantar fasciitis or recurrent
Hmm.
tendonitis, it's like more than just like, like a fracture, but these connective tissue related.
Chronic aches and pains.
Yeah,
Yeah,
that's exactly right. Yeah, it's a real thing. We know it's hormonally driven. There's some thought that it is related to mast cell disease and the fluctuations of hormones that trigger mast cells, which cause inflammation that's there. But anyway, we're working out those details. But this is real. This is not just like I'm being dramatic or, oh, I'm getting old. There's real reasons for that. And so that's where the weightlifting and hormone therapy can be particularly helpful in mitigating some of those symptoms in addition to the.
absolutely. And it can have huge effects on your mental health and quality of life. So go ask for help. You're not crazy. If you're hurting, find a practitioner who believes you that you're hurting and ask for help.
Yeah, awesome. Andy, thank you so much for just giving us a sense. So, like, there's a lot of options available to people out there. It's not all medicine. It's not all one thing. It's really about finding what works for you. And believe me, if I knew the algorithm that worked for 100% of my patients, I would be, giving it to everyone and making a lot more money. But the truth is, like, figuring out what works for each patient is what I think you and I really enjoy about the work that we do, because it gets to be unique to the individual.
And it is a lot of trial and error, and that's okay too.
Yeah, it is. It is.
Yeah.
Well, thank you for being with us today. Thanks for all you do to take care of folks here. And y'all can look
Thank you.
for Atlanta Dance Medicine. Thanks for being here.
Bye. Good to see you.
Good to see you.